Rishi. Good morning, everybody. At the outset, I would like to thank Rishi for inviting me to be part of this symposium on advanced microbial keratitis. Well, basically in this presentation, I'll be taking you through some of these clinical situations. I don't think that is anything interesting that people can have financial interest in. When we talk about microbial keratitis, commonly in the clinical practice we come across bacterial and fungal corneal ulcers. Often you can get viral or acanthamoeba. These are the kind of four common etiologies that you come across in your clinical practice. As we have been taught in our medical school and in our ophthalmology training, when we look at an ulcer in the early stage, there are certain features that help you kind of get an idea of what could be the etiology for this infection. Like in bacterial keratitis, the clinical symptoms are much more rapid, and you have this mucoid discharge kind of thing sticking to the ulcer. They are very focal, and you have a hypobion that increases quite rapidly. And some of these features tells you that this can be a bacterial ulcer. Or when you look at a fungal ulcer which has a dry-looking surface, and you have these feathery margins and then satellite lesions, you have a clinical idea of this can be a fungal. Or for that matter, if you look at a dendritic lesion, you know that this could be viral etiology. Or if you look at a ring infiltrate or something like a string of pearls or wheat pattern, these are again classical description of acanthamoeba or nocardia. So this is where in the initial stage, sometimes looking at the clinical picture, you have some idea as to what could be the etiology. But in advanced microbial keratitis, when a patient comes with a very advanced picture, none of these features can be, you cannot look at a clinical picture and decide that, this could be the etiology in this case. Why do we get advanced microbial keratitis? I think sometimes it's to do with the type of organism. You have either a multi-drug resistant organism that has caused the infection, so that despite the initial medical therapy that's been given to the patient is not responding, or maybe you're not giving the right kind of medication. So that's where the second point comes in, that you have an inappropriate treatment. That means you may be dealing with a fungal keratitis and you think that it's bacterial and you're only treating with antibiotics and the patient does not respond. Or you have something else like an acanthamoeba or a microsporidia and you keep treating with antivirals and you have a patient that does not respond. Or sometimes you have something of a viral etiology and you think that this is something like allergic eye disease and you add steroids to the regime, and these are all things which can make the clinical picture sometimes very confusing. And often with patients with advanced microbial keratitis, we find that the patient is using a cocktail of antibacterials, antifungal and antiviral, all put together, and he's putting everything in the eye. So sometimes it's very difficult to determine what is working, what's not working, or whether it's totally a toxic medicamentosa kind of picture. And often the advanced microbial keratitis have associated risk factors like history of extended contact lens, or some refractive surgery procedure like LASIK, or even with cross-linking. If you see some of the keratitis that have happened after cross-linking usually progress to advanced microbial keratitis, or sometimes after some sort of corneal surgery when you get an infection. And because especially corneal transplants, when patients are using steroids and you have an infection that sets in, often it progresses quite rapidly to an advanced microbial keratitis. And the other reason would be when a patient has an altered defense mechanism, either because the tear film is deficient or there is some lack of thermos or exposure. And in that situation, when you get an infection, this can, the body's defense mechanism cannot take care of it. So then again, it leads to rapid progression. Just to show you, if you look at these three clinical pictures, they all are advanced microbial keratitis. And if your clinic, if you see this picture by looking at the eye, I don't think that can come across to us as to what could be the possible diagnosis. Like the last one, although it looks like a ring infiltrate, when it was scraped, it turned out to be filamentous fungi. The first one, which although looked like a very advanced fungal keratitis, turned out to be acanthamoeba. And the second one was, like a total corneal melt, turned out to be, Pseudomonas drug resistant. Sometimes it's not just the lateral spread which fills up the entire cornea. Sometimes it's the deeper extension of the infection which is also considered as advanced microbial. So although it may be in a smaller zone of the cornea, but if it progresses deep very rapidly, it will still fall into the category of advanced microbial keratitis. And often, why these are clinical emergencies? Because a lot of these advanced keratitis we can quickly go on to operation, and if you don't address them at the right time, sometimes the infection can go to the posterior segment and you can even lose the eye. just to give you some example, now this is a 12-year-old girl, and she had a simple corneal foreign body which was removed by the primary ophthalmologist, and the eye was patched. And next day when the patch was removed, half the cornea was filled with infiltrate and had a greenish exudate from the eye. Patient was started on the 4th generation fluoroquinolone, but within 24 hours, the patient presented with this clinical picture to us. And by the time we took a scraping, we found that gram-negative organism, and by the time we could have culture report next day, this is what the patient's picture was. So we had no other option but to intervene and do a large diameter therapeutic keratoplasty. This patient, again a contact lens wearer, had some irritation in the eye, went to the pharmacy, took over-the-counter medication and started applying. And the best part was she had irritation in the eye, she had redness, she was applying some antibiotic that she got from the over-the-counter, but she continued to wear a contact lens because she didn't want to wear glasses. And finally, when it came to a point where she could not bear it anymore, this is what it presented with. So when we looked at it, again, this was a scraping done. We found that again it was gram-negative organism, treated successfully. Again, this was again, like I showed you, that this was a patient, looked like a ring infiltrate. Clinically, when we looked at it, we thought, okay, this must be acanthamoeba, it's a very long-standing and not responding to medication, but when we scraped, we found filamentous fungi, and this took a long time, almost 2 months of therapy, and finally we could get the ulcer to heal. Corneal transplantation, any infection happening is an advanced microbial keratitis, even if the infiltrate is small. Why? Because you have a patient that's already been on steroids. And if you get an infection, first thing you have to do is to stop the steroids. So if you don't treat the infection early enough, you can then lose the graft. So any small infection in the presence of a corneal graft is termed as advanced microbial keratitis. This is a patient who had again an infection, treated for a long duration of time, and this is acanthamoeba. So sometimes when you are treating advanced microbial keratitis, you should not allow the infection to reach up to a stage where later on, even if you do a surgery, you may not be able to salvage the eye much. So the decision to intervene surgically also has to be at the appropriate time. This is a patient again, was treated as fungal, then as viral, and people did not have diagnosis, and patient had waxing and waning symptoms. Both the cases are two different cases, and they had microsporidial stromal keratitis. So the thing is, in this presentation, what you have seen is a very clinical picture, what you see when you have advanced microbial keratitis. And I think it's not appropriate that when you see a patient with advanced microbial keratitis that you still take a clinical judgment and start treating based on what your gut feeling is. I think in advanced microbial keratitis, you need to have a definitive diagnosis. And sometimes if a patient is on a lot of medications, sometimes it helps to stop all treatment for a day, just put the patient on some cycloplegics and lubricants, and then maybe do a microbiology. Otherwise, if you just do a scraping, sometimes you will find that neither does it show anything on the smear, neither you get anything on culture. And for me, my threshold of doing a biopsy in such kind of cases is very low, because I know that patient has been treated with so much of antimicrobial that usually on the surface you may not get any specific diagnosis. So treat it as an emergency, take a biopsy, get a diagnosis. Biopsy, I always divide into 2 halves, because sometimes it takes a long time to grow in the microbiology. Sometimes the histopathology can give you some idea as to what you're dealing with, especially when you're treating with acanthamoeba or you're dealing with microsporidium. So basically, for advanced microbial keratitis, the etiology cannot be assessed based just on the clinical presentation, although sometimes the history may be, helpful. But still then, so let's say somebody has a history of contact lens wear. It can be bacterial, it can be acanthamoeba, sometimes it can even be fungal. So just based on history alone that somebody has a trauma with a vegetable matter or tree branch and you say that this is fungal, that's not correct. I think that here in an advanced microbial keratitis, having a microbiological diagnosis is very essential, because you are at a state where the cornea is almost involved, and if you don't treat appropriately, you can sometimes lose the eye. Even if you were to do a therapeutic keratoplasty and you don't send the button for microbiology, you can have a recurrence of infection in the post-operative period if you don't know what was the primary infection that led to that picture. So very strongly recommend that the appropriate diagnosis requires microbiological investigation, and in most of these cases it requires surgical intervention. So that's a short presentation on advanced microbial keratitis, the various etiologies and the clinical presentation. I invite you to our second national meeting of Cornea Society of India, the Keratocon 2014, that's in Mahabalipuram, 20 to 21st December 2014. More information on the webpage, corneasociety.india.org. Thank you.